All right. We're just going to give people a few more minutes to come in. So thank you guys so far. Those of you who have coming on in, we're just going to give people a few more minutes and we'll get started around 5:05. All right. Well, thank you guys so much. We'll cut out our jazzy music. I hope you're feeling jazzy. Thank you guys so much for joining us with our talk today from Birthing the Magic Collaboratives. Check your bias at the door. It puts melanated mamas at risk. I am your moderator for today. I am Dr. Jess Daigle. My official name is Jessica Daigle, but fun fact about me is I go by Dr. Jess because my sister-in-law also has the same name, Jessica Daigle. So we didn't want to get confused on social media. I am a board certified pediatrician and I am a NICU and pediatric hospitalist, which means I see all new babies when they're born and help them if they have to go to the NICU. And I'm also the founder and CEO of Mom and Me MD, which is a concierge style in-home and virtual care practice in Atlanta designed to help new moms and their babies and NICU moms transition home with their new little ones. So if you are in the Atlanta area and you're like, I would love to have that lady come see me and my baby at the house, I'll give you information on how to connect with me later. But today we're talking about a topic that is very important. And if you are like not hiding under the rock and you're anywhere on social media, you know that this week is Black Maternal Health Week. And a lot of what has been talked about is the care and problems with the care of our melanated mamas, our Black and Indigenous people of color. And one of the biggest topics that have come up is one of the thoughts associated, we think, with some of the issues around that care is bias. And so we have some lovely panelists that are going to educate you and engage you in this discussion. And we will also love to hear from you. So our first panelist is Dr. J, and she is a respected midwife, educator, and author who has attended over 900 births during her 19 years in a collaborative hospital practice. She is also the CEO of Transition Women's Health Consulting and holds an appointment at Columbia University as a clinical instructor for graduate midwifery students. So passing her education along. With a vision to decrease maternal mortality in women of color, Dr. J is a national speaker, course creator, and diversity trainer who believes in partnering with women in their care. Her cutting-edge program, Black Mothers Interrupted, has made her the go-to professional for bias education in maternal health care. Welcome, Dr. J.
Thank you.
Our next panelist is Mia Malcolm, who is an advocate, DEI advisor, and program manager for equitable patient family-centered care at St. Louis Children's Hospital. She began her journey in healthcare 13 years ago when her son Gavin was born at 24 weeks, and her experience as a NICU mom, paired with her expertise in the DEI space, make her a sought-after advisor and advocate for many. And for those of you who are not aware, DEI is for diversity, is it equality or equity and inclusion? So want to make sure you guys use that, since we use a lot of acronyms in the healthcare space. Mia is the co-author of 2 publications on racism and quality of neonatal intensive care services, on several local and national committees and task force related to diversity, equity, and inclusion in healthcare. She is passionate about advocating for the voices of families and communities that have been underserved, and fights against biases that permeate medicine in predominantly white spaces like hospital systems. Thank you for joining us, Mia. Love your topic, by the way, and your passion. And last but not least, certainly, is Ms. Raven Ray Thomas, who is a healthcare professional with a passion for maternal and child health. With over a decade of experience as a registered nurse, she has primarily worked in public health, focusing on supporting mothers and children. In addition to her nursing background, Ms. Raven is a certified holistic doula and breastfeeding specialist. She is currently pursuing certification in perinatal mood disorders, me too, recognizing the need for comprehensive care for maternal mental health. Raven is also active in her community, serving as a board member for several organizations focused on maternal and child health. Welcome, Raven. Okay, so just to give a little bit of background again about why we're talking about this today. When we talk about bias harming Black birthing people, we are referring to negative impact that stereotypes, prejudices, and discriminatory attitudes can have on the quality of care that Black birthing people receive. Research has consistently shown that Black birthing people are more likely to experience complications during pregnancy and childbirth, and are more likely to die from pregnancy-related causes than their white counterparts. One of the factors that contributes to these disparities is bias, whether explicit or implicit, from healthcare providers. And this bias can lead to delayed or inadequate treatment, misdiagnosis, or lack of appropriate care altogether. Therefore, it is important to recognize and address bias in healthcare and to ensure equitable and high-quality care for all birthing people. So we will start off with Dr. J and let her kick us off into explaining what it is really meant by implicit and explicit bias. Thank you, Dr. J.
Hi. So implicit bias is when we judge someone, we prejudge them from just looking at them without getting to know them or knowing anything about them. And it can really put up a barrier and prevent connection with our clients and our families that we serve. It's unconscious, and it's a false narrative in which you become the author of another person. You make up a whole story about them that is totally dependent on a reaction or a characteristic, such as the color of their skin, their age, a disability, or their gender identification. And it is unconscious. In our world, we do it automatically. Like I said, it's unconscious. So what I've found is that we're all biased.
That's a good talk. Anything you want to add to that, Mia?
No, I mean, I think that one of the things I think about with biases in general, right? Like, I think that we've kind of like bought into this idea that bias makes us bad people. And so a lot of us try to deny that biases even exist in us, but we need to normalize the idea that everybody has them. And the goal is not to eradicate bias. The goal is to learn how to check your biases, right? To like, oh, okay, this is popping up. Where is that even coming from? You check it and you move it out of the way so that it doesn't influence the way that you are treating people. Because when it goes unchecked, that's when it gets harmful. That's when it becomes dangerous, when you're letting it influence the way that you are interacting with people. So we can't sit around and be like, that's not me. I'm not that person. You are that person with bias. You are, I am, we are. Yeah, and the goal, right, is to check it, get it out the way, and let's move forward with the interaction. So that's all I would say.
And I would even say that more than like getting it out of the way, seeing how is the bias even operating, right? So like right now, us even having this conference is a sort of bias. Someone could say, well, what about me as a white person in my maternal health, right? Or something like that. But the point is we're using a bias of specifically choosing to help Black women this way to provide information to improve, the care around them. So again, like you're saying, is what is that bias and what is it doing? And is it causing harm, or is it helping us to help a certain set of people? Because we do have differences, and that's where the bias come from. I like to say that bias, and we're all a combination of our exposure, our education, and our experiences, right? So if you've never experienced something, you're going to automatically have one frame of mind, but it's being willing to say, maybe I need to consider something else, and that's that checking that you talked about. Good deal.
Exactly.
Okay. What about you, Raven? What do you have to say about that?
I mean, I feel like y'all have already covered most of the bases,
Okay.
especially when it comes to being self-aware, right? That's the most important thing, is not living in la la land as if bias doesn't exist, or that I don't have bias even with my color skin in this maternal mortality crisis, but being self-aware and understanding even I have bias and understanding where it comes from.
Right.
So you say that you have bias. Can you give us an example of a bias that you've personally identified, and then how do you check it, as Mia suggested?
Absolutely. So I will say, before I got into the maternal health space, I did work as a bedside nurse, right? And I remember thinking, because this is what I was taught in nursing school. Now, I remember being taught this in the textbook, that Black people don't need as much pain medicine because they have a higher pain tolerance. So me working as a post-op nurse, I'm coming into my Black patient's room thinking, oh, you're not really in that much pain. So then when my post-op patient has a higher blood pressure, I'm ignoring the fact that I'm not adequately managing their pain because of this thing that I was taught way back in nursing school. And then we talk about like how Black people are having poor outcomes after C-sections. But what if all of the nurses are coming in and they're not even treating their pain? They're not even taking them seriously when they report their pain.
Exactly.
That's so good. And that's a good example of misinformation, causing you to make a decision, and you had good intentions, but because you had the wrong information, you're making some decisions that's still costing someone issues with their care. Any example that you have of, Dr. J, that you could think of a bias that you had that you've had to check, so to speak?
Yes, I can tell you two quick examples. The first example, I didn't know what I called it at the time, but I knew I felt wrong, and I was wrong. That was when my father was very sick. He had a cerebral hemorrhage, and he was unconscious upon arrival to a hospital. My mom and I didn't even know he was hospitalized for about 12 hours. So he laid there unconscious in this hospital all day. And when we finally found out, they called us and we went to see him. He was the only person of color in this hospital. We walked into a hospital that no one looked like us. My first impression, I have to be honest, was, oh my God, they're not going to take as good of care of him as they would of the other patients, for a few reasons. He's a Black man, he's unconscious, they didn't get to meet him, and he has no family support. Do they think nobody cares about him? But I have to say I was so wrong. They took exemplary care of him. And I love these nurses to this day. And that was my bias. But at the time, I didn't know what to call it. Fast forward, as a midwife, I can remember a patient missing a lot of prenatal appointments. And the conversation at report was, she's been absent from care for 4 months. We haven't seen her. She hasn't done her meds. She hasn't done any of her tests. She hasn't done her sonogram. So basically, she was going to walk into a adversarial kind of situation. And she ended up on my panel that day, and she came in, and I didn't join in the conversation, but I didn't stop them either. But when she came in, I sat and talked to her. Come to find out, this young lady had lost her husband during this time. She had gotten a job. She had other children. She was working on a job. She couldn't take days off. She would have lost her job. And we didn't have hours that accommodated her to come to clinic. And she was in grieving process. And if we didn't sit and talk to her, we would have never known that, So we just, it was like, come in. When can you come in? I used to come to my office early so she could come in before work. Or I would stay late, so she could come. We have to accommodate patients, but we won't know that unless we sit and talk to them. And if we have a bias, she's a young mother, she doesn't care. And we operate from that perspective, how are we going to even know her story?
That's
So,
really,
you know, that was a bias until I sat and talked to her and realized, you know, she has a story. Everybody has a story.
yeah. There's
Mhm.
one that came up for me recently, especially as a doctor in the NICU. And so I remember being a trainee. And so when you have these babies and they're like the wimpy white boy, right? And so you're like, the nurses will be like, oh, it's a white boy. That means, you know, he's going to be like really wimpy. He's going to have trouble breathing. And then if you have a black baby, they're going to do really well. And so I remember being horrified, like, y'all go around like saying this stuff to people.
They
And
do.
then I started to look, and by all accounts, in most cases, medically, that would be true. But what I have found that happens is it actually skews the care, because what happened is, you know, now the white baby will get all that attention because the assumption is, well, this black baby is going to do fine. And so it's actually impacting the type of care when they look and do like the research and stuff at the race and stuff in the NICU. And so I've had to, now I start to say something about that. When we say that, I realize, like, while, you know, it might be good to think about based on the science of it, that might be true, but unintentionally is infecting how people are providing care. And I remember I was talking with another nurse on labor and delivery who said, like, now that kind of sickens her. And she says, because, you know, it's almost like Black women, Black girls especially, because they do tend to do pretty good. Well, I have to say that. But we're already just getting tasked with, oh, they're going to be all right. Like, you're going to be all right, you know, from the jump, right? That whole mindset of like that same thing that's playing into the, you don't need as much pain medicine. Like we're somehow impervious to pain or trouble or struggle, right? Because of being Black or whatever. And so that's the thing I've had to now realize, don't keep passing that along or using that language. And even in telling your families that, like, you can use it to encourage them to say statistically this or that, but we still need to make sure that your baby's eating well, that the oxygen and the jaundice and all the other things that we would tell for other families and things like that. So that's one that recently came up for me that I started to realize, like, while we might have had the intention of using it to encourage Black families, especially, we're doing a disservice in a system that's not necessarily caring about them in that way. So how can, there was a question in the chat, and I guess from a Malcolm Clay, and he's asking, how can men help take part in the maternal child health movement, especially when in hospital medical spaces with gaps in medical knowledge and communication? So I think the question is, how can men participate, being a man that may not will not necessarily have that lived experience of being the woman, you know, having the baby and undergoing the labor and delivery process the way we do as women, I would assume.
I think that this is really, I think this question really leans into the idea of bias, right? I think at our hospital, we actually had to start when I was actually a part of the idea, because we started this Fathers First initiative because the building where, people have the babies is called Women and Infants, which great, right? Sure. And in the NICU, we come over and everything is about mom. And
Sure.
hey, I'm a mom, I'm on board. I had the boy, right? Here for the moment, right? We're talking about maternal health weeks and all the things. I'm a mom, I had the baby, I'm on board, I support it. And however, right? There is a thing that happens when that baby comes over from Women and Infants, is that a lot of times they come over and there's this person that's standing at the bedside watching everybody admit that baby. And whoever he is to that woman, is standing there with this welcome packet and he is shaking like a leaf and he is terrified. And I, as the family partner, often have to walk up to him and place my hand on his back and put a chair behind his knees and say, hey, I'm Mia. I need you to sit down. I need you to unlock your knees because you're about to pass out. And I know you don't think you are, but you're going to because you're not breathing. So I want you to take some deep breaths and unlock your knees. I'm going to have somebody grab you some water. This is what we do every day. We got you and we got this baby.
I love that.
Okay. I got you. But everybody forgets that there is this guy, whoever he is to her, right? If that's her husband, her boyfriend, her ex, somebody she met at the corner store, I don't know, and it's not my business.
Right.
But whoever he is, he
Yeah.
feels responsible for this baby and for that girl, right? They belong to him in some way, shape, or form. In his brain, there is a responsibility in this space, and we have all forgotten about him. We have
Yeah.
forgotten that he is responsible for this journey that they are all about to go on.
Yeah.
Whether or not she keeps her milk supply up to take care of this baby, somehow he's responsible for all of this.
Yeah.
And when there are questions asked, we are all looking at this woman, and we forgot about this guy who was standing there shaking like a leaf, terrified that one day, right? And
Yeah.
so there is a thing that this man is responsible for, and everyone has forgotten to talk to him, to educate him, to
Yep.
make sure that he knows, to make sure he's up on, right? And so when she don't show up for appointments, it's all her fault, and nobody has remembered that this man
Needs
is
to be.
also there and responsible, right?
Yeah.
We've taken him out of the equation at every step,
Yeah.
but then at some point, everybody's gonna look at him and say, but you were responsible.
Yeah.
Oh, now he's responsible. Now we need him for something.
Yeah.
But for all this time,
Yeah.
right? And so I think
Yeah.
that we as medical people have a responsibility to remind ourselves, to remove our biases and our blind spots, and remind ourselves
Yeah.
at
Yes.
every step of the journey that he's there. And he deserves the information too. He deserves to know what's happening with that baby.
I agree.
He deserves to know what's happening with her.
Yeah.
How can he support her feeding? If she wants to breastfeed, how can he support her in that journey? Every time, if I see a mom or a birthing person that's in that room and they are pumping and he's sitting there, I'm like, hey, when they done, make sure you grab those supplies. You want to know how to wash that stuff out while she's getting everything back together. You want me to show you how to wash? Oh, can I help with that? And you sure can. You want to do some skin to skin after that, bro?
Yep.
Right.
Let me set you up.
Yep. I do that
Right?
too. Yeah.
That's right.
Because
That's
the
so good.
idea that skin to skin is only her job, she tired.
Yeah.
Let her go rest. Let him hop in.
Yes.
Right? That's our bias, that she's the only one that can do that.
I agree.
He wants to do it too.
Yeah.
Tap him in, put him in, coach.
That's right. That's right.
Yeah.
Put that father first.
Yeah. I love
Let her
that.
take a back seat. She want to. Trust me. I want to. For 14 years, I want to go sit in the back seat. Let somebody else drive the car.
Right.
That's true. I love that. Love all that you said, because I'm more and the commonality around this talk with bias is, one, the awareness, like Raven brought up, is first acknowledging the awareness, your self-awareness, and then it's being intentional, saying, okay, I'm going to work at, it's a skill like everything else. I'm going to work at making sure when I see the dad the next time, it's like learning from every experience. So now someone here, if we have some attendee that, I never thought about that. Tomorrow they're gonna go to work and they're gonna be like, they're gonna look at that dad a little different and be like, let me tell him he can come and do skin to skin, because I started doing that too. Like I mean, like, you want to hold, and I'm even more intentional. Like today when I was talking to the family, I made sure to look at the dad and the mom in the face, not just talking to the mom. I'm like, I look at both of them like, all right, I'm talking to both of you about what we're doing. I'm talking to both of you about what to do when you take this baby home. And so you're right, it's about being intentional. And so what that leads into one of the other things that came up was how can a healthcare provider be trained in to recognize and address their biases to provide equitable care to Black mothers? If you want to take that, Dr. J.
Yes. I just want to say that all of us that are in healthcare took an oath and to do no harm. And implicit bias does cause harm, and it causes us not to see these people as individuals. So it causes us to assume, and we've got to do better. So we can do that through group education, through self-assessment tools, talking through examples of bias, just like we're doing now. Because when we start talking, you're like, wow, I didn't recognize that as bias, but then you start to recognize it. Also, it shows that all of us are biased, and people should not be ashamed to be able to say that. They should own it. it also highlights the differences that people are facing. You start to hear different scenarios and like, wow, I never thought of that. We
Yeah.
walk through life and people wear masks and we don't share personal information with healthcare providers because of past traumas and because we don't trust them yet. So we do different exercises when we have the staff education with the students. I love to be with medical students and do some of the exercises with them. It
Yeah.
shows how different our lives are from even our colleagues, and they
That's true.
start to understand that we see the world through our own lenses. You only know what you know. And when you
Mhm.
start hearing other people's experiences and things that they're going through, it's things you never even considered because you never dealt with that kind of thing. So after seeing those kind of differences, then we should be starting to realize we need to get to know each person one-on-one as we face them. So when a
That's
patient sits in front of you, I don't care what you heard in report, this is a difficult patient, she is non-compliant, she is this, that, and the other. You
Yeah.
walk in that room and you care for that patient one-on-one, you meet her where she is, and you make your own assumption and information with her once you get the information.
Ooh, that term difficult burns me up, Dr. J.
Burns.
Me
Burns
too,
me up.
me
You
too.
want to be
In
mad, call
fuego.
somebody
Yes.
difficult. I'm like, you probably was being difficult. That's probably why.
They probably kept that same energy and met you where you was at. That's why they was
Exactly.
being difficult.
Exactly.
Hello.
They like, yeah, exactly. They was just standing up for themselves. Shucks. I was like, and every time I go in and talk to them, baby, I get a different outcome. I'm like, well, they couldn't have been too difficult because we were able to come to a conclusion and reach an agreement and get what we need to get done. You know, a lot of times that they needed one trust. That's that like knowing trust factor they talk about in social media. That works in healthcare too. People want to trust
Absolutely.
that you
Absolutely.
actually care about them, right? Like you're not just coming in there like the old run of the mill. Let me just come in here and say I checked it off and did it. No, I see you as a person and you matter to me and your care matters to me. So what you have anything else to add, Raven, about what Dr. J too about the training and recognizing bias?
No, I wanted to chime in on the whole idea of a patient being difficult, right?
Yes,
Because
right.
now that I'm in the doula lane, I found that most people who are being labeled as this difficult just want to understand what is happening and what is going on, right?
Right.
So I feel like healthcare providers cannot just label a patient as difficult because their ego is being challenged.
Ooh,
That's right. Ooh, say it.
That's it. That's all I got. That was it.
That's a mic drop moment right there.
Can I
Because
say
that's so good because even when I have found that I have had a patient that I felt was being difficult, and just to say that I'm just like, why, you know what I've done? I've stepped back and said, what am I not communicating to help them? Like there must be something that I'm not saying that needs to help them understand the decision that we need to make. Because I know this mom cares about her jaundice baby or whatever. So maybe I'm not explaining what the level is, what we need to be, what we're looking at, why we're doing it. And so now that's why I give such a thorough, detailed thing on jaundice. You would think they're getting a class on it. But it has made a difference. It has really made a difference in my interaction with patients. Like I had a mom today tell me, you were just so thorough. Like I had to tell her baby had a VSD today. She was like, that was a really good, thorough explanation of the heart and the function. But it helped her to understand what we need to do next, you know, and they usually are like, we don't have any questions because I took time to care about what they would need to know. Go ahead, Mia.
I think I two things. I think the first about the idea what Raven was saying, you know, I talk a lot to a lot of our clinicians and physicians about the idea of questions. Just because someone is asking you a question does not mean that they are questioning your abilities or your, you know, your medical license or they just asking a question because they didn't go to medical school. I know that that's complicated to understand that everybody wasn't in your graduating class with you, but they wasn't. They wasn't. Maybe they were a teacher before they had this baby, or maybe they were, you know, a pharmacy student, or maybe they worked at Berkeley. I don't know what they was doing before they got here, but they wasn't in your class with you. And even if they were, I had a doctor who literally was a fellow in our NICU, had her baby ended up coming to the NICU. And when I tell you, you would have thought she had never seen a medical book, because you know what she wasn't anymore? She wasn't a fellow. She was a scared
mother.
parent. She
Yep.
was terrified.
That's right.
She was terrified. And it wasn't her job to be her baby's doctor. It was her job to be the mom. And she was scared. And
That's
everything that she thought she knew had gone out the window. And so I just think that if we could put it in perspective, that
That's
just
good.
because somebody's asking you a question, that's all they're doing. They're not questioning your abilities. They're just asking because they don't know. They
That's
just don't know. And I
Right.
think to the idea of like education and things like that, during all of the rounding and stuff that we do, if we could practice the accountability that we expect for parents to have with each other, I think that we could go a long way, right? Because the idea that we expect for a parent to have some sort of accountability with us, we expect parents to give us grace when we mess up, but we don't give parents grace
I agree.
when they quote unquote mess up, right?
Yeah.
But we expect for people to give us grace. So if we could practice that with each other. So if we are in rounds, me and Dr. J are in rounds, and I hear Dr. J say something, and I'm like, pineapples, wait a minute now. Hey friend, and maybe I don't say it in front of everybody. Maybe I pull her to the side before we get to the next patient. Hey, when you use the language, this and this, I think that maybe for next time, because that language isn't right. I'm sitting in rounds and I hear you talking about this baby and their feeding journey. And when you were talking about that baby, you talked about how successful they were and how they did such a great job and they succeeded. But when you talked about this baby, they were aggressively attacking the bottle and they were fighting through this. But the only difference I saw with these two 27-weekers is that one was Black and one is white. Why was the Black baby aggressive
That's
and
good.
fighting,
Right.
but the other baby was successful? And you're so proud of how that language feels a little bit different. I'm just wondering about those differences. Can
That's
you
right.
walk me through that, right?
Yeah.
Hold your colleagues accountable the same way
right.
that you would hold me accountable if you felt like I was doing something wrong, if I wasn't feeding my baby, or if I didn't show up enough, right? You would say something to me as a parent if I'm not showing up the way you want me to show up,
Yeah.
right? Hold your people accountable the same way you hold me accountable. If I'm not a good enough mom, you would tell me,
Yeah.
or you would tell social work, you tell somebody, amen.
Amen.
Say something to
Definitely.
your people,
Yeah.
because you can do that.
Yeah.
Right.
Create
I
that
challenge-
space.
Yeah. I challenge the nurses like that too. I had a baby. And I've mentioned on like social media how sometimes I'm the only Black person somewhere sometimes. And sometimes I forget that when I'm in Atlanta, I'm like, because I see a lot that look like me, and then I go like Mississippi, and I'm like, oh, I'm the only person. But sometimes it even jars me when I'm around and I'm like looking around like anybody else? But I've had to challenge them too. Like I had a baby that was going home, and there was some situations, and I was just like, so what made you concerned? It's like seemed like they were so irate that this baby was going home with this particular mom. And I'm thinking, like especially when it's like a drug related case, and I'm like, I don't see this much passion when it's like a meth baby and they're like mom or whatever, and so the mom has smoked marijuana for whatever, and and I don't want to get into all that kind of stuff, because I just still think that kind of stuff is interesting, because I'm like, well, if it's legal over here, it can't be that bad, because it's legal in Colorado, so I don't know what the difference is, except we're in a different state. But my point is that I begin to notice those kinds of things that you point at me, like, and I've started to ask myself, so in their mind, like, what made it different? What made it okay for this person versus like not this person? And I used to not be a person that bought into, like, I knew racism and implicit bias existed, but I just never really focused on it as much until I started like working, especially traveling and going to different places. I started to be like, for me, this is the only apparent difference, So I do now make comments. I do ask, like, so can you explain to me what mine is expressly different? And they're kind of like,
Yeah.
because now I'm challenging them, because I want to challenge that kind of thought. Like, no, and why is that mom aggressive because she didn't X, Y, and Z, that word is used, like that's not appropriate, and just stuff like that. So I do speak up to your point now, I do.
And I
So
think that speaking
Raven.
up, I'm sorry, I think that speaking up is the only way that we're going to address and undo these years and decades of teaching this bias and all of these misconceptions. I saw that question in the chat about if the pain thing had been addressed. And I feel like this is more effective than waiting for the textbooks to change.
Yes.
It just
yes,
came
it
out of
is.
the textbooks. It just came out of the last nursing round of textbooks in 2018.
Yeah,
That
It was
Black
actually in
women,
the textbook.
Yeah, it was
it
in
just
for a
came
while.
out. It just
See,
came
I
out of the
didn't even know
last
that.
round of nursing textbooks in 2018.
Wow. And see, even stuff like that's not the kind of stuff that I was necessarily taught in. Now, I didn't see that in any of my medical school, but then I would have to ask one of my OB colleagues if that's in any of their books, like in the physician books, but definitely didn't see it in anything like in pediatrics for sure. But that is just so interesting. Oh,
2018.
Yeah.
wow.
But
Well, how
even, I mean, to that point though, like even if it's not like, that specific language, I think that, when we talk about like the wimpy white boy thing, understanding the intention and
Yes.
then being accountable to the impact of it are two very different things. Because I know that for me, hearing that didn't make me feel like my son was going to be okay. It made me feel like if there's one vial of medicine that's left,
It's
you're
going
gonna
to the
look at
for
my
the
little
kids.
black boy and you're gonna be like, he all right, he fine, he'll figure it out, or maybe he won't. We don't know, but we know that this white boy, he's scared
that is
and
a
he
good point.
needs it, and he's so fragile, and we have to give it to him because without it, he's definitely not gonna make it. Now, this black boy, he'll figure it out, or maybe he won't, but we know he has a better chance. So we're gonna give him this white boy this medicine. That's what it made me feel like. Whether or not that was your intention, that was the impact of me sitting in that room with my 1 pound, 8 ounce baby, who all I saw was his struggle. I didn't see the strength of whatever your numbers and all, whatever you had going on, that was your business.
That's so good.
I was terrified because my baby was fighting for all of his life. And I was swimming and drowning, and mostly drowning. I didn't have what you had, and I didn't want it because all I saw was what I saw. I was experiencing my experience, and hearing y'all talking about wimpy white boys was a no for me.
Right.
It was a hard pass. Hard pass.
Well, you know what? I'm going to go live this weekend and I'm going to bring up exactly what you just said and we're going to talk about it.
It was a hard pass for me. I didn't have it.
Yes. And from now on, when somebody said that, I'm going to say that's not appropriate. We're not going to use that no more. We're not going to use that. That's so good. I never thought of it from that way, but you're right. It does. You're right. The language and then the impact are two different things. And you know what's even more scarier is that you may know this because you were on the medical side a little bit, but these conversations are happening in the background where you may not know, right? A mom may not know that this is, and then how that is factoring into the psyche of the physicians and the caregivers and the decisions that are being made. This is life-changing for me, y'all. All right. So how can Black mothers be empowered to advocate for themselves in a healthcare system that is not always responsive to their needs and concerns? And this is one of those questions that I really want you guys to speak to, because I try to do my part when I'm rounding, and I try to tell families if they don't feel like anybody, like, look, call me. I'll call OB myself if I have to, but it can be a lot because it's just so overwhelming already. You're just had a baby, you're trying to look out for yourself. And then, so it's two issues. One, a lot of people don't even know, they have the education a lot of times about what's even wrong to advocate for themselves, right? Like to say, this may not necessarily be good, so I need to tell somebody about it. And then why should you have to keep like harassing a nurse or somebody else to call a doctor to come and see about you and your situation? So what can a mom do if she's faced with these types of scenarios? You want to take it, Dr. J? Or Raven? Raven, go ahead, Raven.
Go ahead, Raven.
No, Dr. J, you can go ahead. I'll chime in after you.
Okay, first of all, moms are hearing now that we're doing this more public that Black moms are 3 to 4 times more likely to die than white moms after having a baby during pregnancy or afterwards. So part of the thing is that we have to educate our moms on what their rights are from the beginning. From the very beginning of a pregnancy, we need to let them know what their rights are. They have the right to prenatal care. In my state, all pregnant women are covered by insurance. So even if they have no money, if they're illegal immigrants, it doesn't matter. They're going to be covered for prenatal care. So they need to know that that's their right. Right there, that gets them into prenatal care, or at least they know that they can come. Also, they need to know that there is something called a doula. A doula is someone who partners with them. They can get a doula from the beginning of their pregnancy to partner with them and their partner, and they can come to their prenatal visits. I really encourage my patients to bring their partners and their doulas to visits, and I try to schedule it so they can come. It's wonderful. They have support. They follow their plan of care that we come up with. And when I say we, they're the center of the care. It's their pregnancy, it's their baby. But once you come up with a plan that is agreeable to everyone, then they follow that care. And that doula supports that mom throughout that pregnancy, right through delivery, all the way into the postpartum period. We also do a lot of education as far as what to look for during pregnancy, during delivery, and even after delivery when she goes home. That mom needs to know about her body. It's her body. Nobody can tell her what she's feeling. And if she doesn't know what to look for, how is she going to come and tell us when she's not well? How are we going to know what's going on? And then the problem I have with this is a lot of times healthcare providers are not listening to Black women. So if we do all this wonderful education, how dare them not listen to this woman when she says, I have a headache, I'm having chest pain. And they ignore them or not listen to them, or they say that, oh, that's normal after you had a C-section, or that's normal, you're pregnant, it's just a pregnancy discomfort. When women come in with a complaint, we need to act on it. We need to rule out everything else before we say it's nothing, okay? When what they have found out is if when two women walk into an emergency room and have pain in the right lower quadrant, the white woman will be sent for testing and they're looking to rule out appendicitis immediately. If it's a Black woman, they're going to rule out PID first, which is pelvic inflammatory disease, which is comes from having an STD. Like, why are we not treating that woman the same? That's bias right there when someone walks into an ER. So it's things like that. And it's done just so automatically and no one questions it. We need to question it. That's us saying, excuse me, why are we not sending this patient for a CBC? Why are we not doing these tests? And if, we should be doing the exact same rule out test for everyone, not depending on their skin color.
I agree. It's good. Now, what you were going to say, Raven, to piggyback.
Yes, I was just going to emphasize the importance of having a doula, regardless of what type of birth you are planning. There's this misconception that doulas are only for home birth or doulas are only for birth center births. And that is 100% not the case, because the education is key, even more key if you are having a hospital birth right now, because you need to understand what to look out for, these signs and symptoms that may get overlooked because your prenatal appointments are being rushed and you don't understand the red flags that you're supposed to be looking out for. And that's where doulas come in. This is what we do. We provide education. It's more than just hip squeezes and cute little sitting on the birthing ball and changing position, but it's the education that teaches people how to advocate, and then having somebody in your corner when you're like, I got a headache, but this nurse just told me it's normal, and this doctor just told me it's normal. But your doula is going to be there and say, no, find me somebody else. We need a second opinion, and we're going to encourage you to keep advocating until you are heard. Whereas some people would just be like, well, the nurse said it's normal, the doctor said it's normal, so it must be normal.
I love that. I love that so much. Yes, I was like, I need to write down all these points y'all done made so I can go make some posts. Okay, I got to clarify some stuff up to my communities. But I did a live actually this Monday with my line sister to answer a question that was in the chat about like women coming in because of the statistics we've been hearing. And like now Black women especially are coming into birthing situations and hospitals and stuff, fearing for their lives. And so they ask, what can we do to help these moms? And so getting a doula is one of the answers. And I think also it is looking at the statistics. So I saw a good reel by Dr. Nicole Rankins, and you guys may have come across her
Yes,
through,
yes.
through LinkedIn.
Mhm.
And I've talked, and I liked how she put it in terms of numbers. So she said statistically in a number is a 1% chance, but like she said, one death is still too many, and especially for the reason why. So if the reason why is because your care was overlooked or you were not treated appropriately, then that is the reason of what we're talking about. Because unfortunately, things do happen naturally, just with everybody. Like there could be something that can happen that is unpreventable. We're talking about the preventable things that the preventable deaths with regard to somebody not listening to someone or giving them some timely care. So getting you a doula, pre-educating. One of the things, 2 of the OBs I saw too talked about that preconception. So if you are here and you're not pregnant yet, and you're going to get pregnant, the pre-work is just as important. Talking with your doctor about your care, understanding your history. If you're already predisposed to diabetes or high blood pressure, optimizing your nutrition, your health, instead of just going into it and then trying to fix things on the back end is good. Just be all concerned about your body from the jump, so that's the advice that I would have to give if anybody to add to that.
The preconception the preconception care is so important to get women into care. Like you said, you want to have all of that under control before you even start to think about a pregnancy if possible.
Yes.
I would just say that I think that one of the things, especially like when you go in and like a lot of moms are very scared, right? That they're going to die. And I think that one of the things that especially healthcare professionals can do is acknowledge that. Don't dismiss that fear is right there, because when you dismiss people's fears and anxieties, it heightens that thing. Acknowledge why they are scared.
That's right.
Don't pretend like you don't know why I'm scared as a Black woman coming into this predominantly white space. Don't act like you don't know why I'm scared. You know why I'm scared. Acknowledge why I am scared. Acknowledge the historical harm that has taken place in places like this with people like me and why it would make me scared. Right? I think about all the time when my son was born, my father when they told me that they thought that my son was going to die because he was a 24-week preemie. It was 14 years ago. 24 weeks was like baseline, like edge of viability. He had a grade 4 IVH. His lungs were like null and void, all the things, right? They were like, that baby maybe got 2 weeks. We don't think this is going to work out. What do you want us to do? They walked out of that room. My daddy looked at me and he said, a 24-week dying little Black boy, that's who they experiment on. They're going to kill your baby. You got to get out that hospital. They're going to kill your boy. What y'all not getting ready to do is sit there and pretend like y'all don't know what I'm afraid of.
That's good.
Okay? You can't pretend like you don't know what my daddy was afraid of. Because there is a historical harm that is taking place that man understood that something wasn't right in the water. Okay? We can't pretend like that's not real for people. You have to acknowledge the trauma that people walk into your space with. Don't ignore it, because if you ignore my trauma, you're ignoring me. It's not baggage. We talk about people having baggage in our space. I can put my baggage down. My purse is over there. That's a bag. My purse over there. I put my purse down. My trauma is in my body. My daddy was wearing his trauma. He didn't put it down. He was telling his baby about it. And he was telling his baby to protect her baby. You dig what I'm saying? Folks have to understand that language is different. Right? That's a different thing that we have to learn how to address in our spaces, because people are not putting that down. Right? And when we are in trauma, we fight, flight, or we freeze. Right? And that fight looks different for everybody. I'm not fighting you. I don't even know you. I'm fighting the thing that you represent because it's terrifying to me.
Right.
When I am frozen, I'm not despondent. I don't not care about my baby. That's my baby. This is my child. This is my life. I care more than anything. You don't care more about my family than me. Stop it.
I love that.
I am frozen because I'm terrified. It's a trauma response.
I love that.
Yeah.
right? When I'm not showing up, it's not because I don't care about what's happening. It's because I'm terrified of the space that you have created, the environment that you have
That's it.
created.
That's
That's not
right.
about me. That's about you. Come
Yeah.
on, y'all.
Yes.
Right? So teach people how to advocate differently in your space because you are aware of what they are afraid of in your space.
That's good.
Create safe pockets. Put people in places that have experienced your space that know how to help them navigate that space so that when things bubble up, they have a safe space to report out the things that they're afraid of. Show them that their opinion and their voice matters in your space.
That's good.
Yeah, it
Those
is.
are the things that we have to do if we want to be different in our space. Show them that you know that how you're showing up isn't always perfect and you don't
Yeah.
want it to keep permeating the medical space that they have to experience. That's how we make real change. We have to value people's experiences and their voices, especially because we recognize that their lens is different than ours. Their experience is not ours.
That's good.
Being Black
Mhm.
is not a monolithic experience. Me and Dr. J, we don't have the same experience just because we Black
That's
and
right.
identify as
The
women. That's
people in
not
the
a
back.
thing.
That's true. That's
Say
true.
it again for the people in the back. I be having to
Right.
tell people that make assumptions about that. Like, no, like we don't all look alike. Like they assume to.
Me and my mama don't have the same experience just
That's
because we
true.
both Black and women and in the same family.
That's
Yeah.
right.
You don't.
I don't even know her half the time, right? Because she came from, it's a different space, place,
It is.
all the things. You have to acknowledge that what I need and what Raven need are not the same thing. But if you don't
Right.
want to talk about it,
That's
then you
good.
don't want to fix it. And just say that.
That's
And we
good.
can, and now I know how to govern myself accordingly in your
That's it.
space.
That's
Wow.
it.
Well, we
Okay.
Wow, Mia.
that is so good. Mia, you need to write a book or
Right?
something. Okay. You need to write a book. I'm just saying. Me and you gonna have to do some lives together. You're so deep in my soul. I just want to listen to you keep talking, but we all on the time crunch.
I'm
okay?
sorry. We done, y'all.
That's okay.
I
That's
just had to
okay.
get that out of my spirit because it's, listen.
Yes.
Yeah. No, I love that though. I love that. All of
Yes.
that. I'm
Yes.
gonna go and write a LinkedIn post and say all that you said and credit you with it. Okay. So as a patient, we have a question from Angelica Richardson. She said, as a patient, what is the best way to bring up bias that you may have noticed from your healthcare provider? And I think it was alluded to today. It's just to be honest and just, one of the ways I would do it is say, hey, I noticed X, Y, and Z, or I've read, or is my understanding that this is the next step of action. Like, oh, okay, my head is hurting. This is a common complaint in preeclampsia. The next course of action should be you checking lab, you're checking my blood pressure. Why aren't we doing that? So that's a way to get the information out, because now you're focusing on the fact of what is required to bring out the information that's needed, as opposed to getting distracted by the, okay, well, I'm Black and they white and then this. Let's get to the fact. The fact is I got this headache, so why aren't you doing X, Y, and Z? And that's
Right.
that the way I would say to do it.
Right.
Malcolm has a question too. Have you seen any examples? I don't know this SOPs. What is that? What do people use that? What they mean from HBCUs? I don't know what SOPs are when people use that abbreviation. From HBCUs that you appreciate use in maternal health because of a standard operating procedures, maybe?
Yes. Yes.
Okay. That you appreciate use to navigate maternal health because of a different standard of care due to cultural similarities. Oh, that's a layered question. Malcolm,
Yeah.
I'm gonna need you to simplify that question. Let me see. Hold on. I guess he's trying to say, are there like policies or things in place, maybe in HBCUs, that maybe do a better job of helping us to navigate maternal health? I don't necessarily feel like that's the case, to be honest. But I don't know if anybody, maybe Dr. J can speak to that real quick.
I can't really speak to the HBCUs. All I can say is education everywhere right now, in the medical education, nursing education, midwifery education, all of it is talking about bias. We're talking about maternal mortality and morbidity. I think that's the big thing right now. They're making it mandatory that different schools and different organizations have classes like annually on bias, and everyone, it's like mandatory at this time, because what's happening, they're finding is Black mothers are being dismissed, and it's leading to delayed diagnosis, poor and clinical outcomes, poor clinical management. And if we look at any of the high profile deaths, that's also coming to to the light with Beyonce and with Serena Williams in the recent years. And pretty much they had delayed diagnosis, and they were very vocal about how they were feeling. And we're not talking about a little poor Black girl on welfare. These are people that are well known. It's not about money or education. They spoke up, and they still were ignored for a while until their diagnosis were finally confirmed. But you know, that's what we're teaching in all of the schools. I'm not going to say just the HBCUs. That should be everywhere. We're telling students, you have to listen to your client. You have to follow up with this stuff. You can't ignore it. I mean, you know, if you're going to be a physician, a midwife, a doctor, a nurse, whoever, you have to listen to your patient. If you're not willing to do that, you need to find another profession.
I agree. That's it. That's the answer. The answer is, and I've been saying it's awareness, curiosity, and humanism. It's really the point is knowing that it exists and then saying we need to do something about it and being willing to do it. I think I put it on the post like your example, Dr. J. So we have so many protocols and stuff. It should be, what is the diagnosis? And then what is required to get that diagnosis? And that's how we should follow with it.
Exactly.
I won't say that is statistically is something more or less likely in a certain group of people. I can't argue that, because just like I use this example, if you have a baby that's low birth weight, they'll be more likely to have a lower glucose. That's not me being biased. That's based on some science.
That's just facts, right?
Now, where bias will get in is if I had the Black baby that was low birth and I had the white baby and I was doing the glucoses on that one, but not the other one. Well, that shouldn't matter, because the low birth weight is what's driving the whatever. And if we're to do no harm, even if it takes a little bit extra more to say, well, I'm just going to make sure that this patient, even though they may not fit the entire profile, but we need to make sure that this thing is ruled out. That's providing the care, regardless of what else may or may not make it happen. It's like, can you be sure that you provided the best care to this patient? If you cannot answer that question honestly, then that means you need to step back and say, okay, well, even though it's not likely, I still need to do X, Y, and Z. And that's the way to kind of address it.
That's the problem with the toolkits. The toolkits are excellent when you look at preeclampsia or diabetes. But if someone ignores when you say you have a headache, or that you're having chest pain, if they don't document it or write it down or even acknowledge it, if they tell you, oh no, that's normal, it's just heartburn, then you don't end up getting towards that toolkit because you're not counted. But if the other person says, yes, I'm having chest pain, and they act on it, of course, now they're going to do the treatment and the diagnosis properly.
Yes. Well, this has been such a good discussion. You know, we're on a rolling schedule and we got to hop and do our next talk and everything. But, just real quick, Malcolm, I'll answer this for you. If you want to go into OB, just show the passion that you have, like anything, like any other field, OB, nursing, whatever, you know, they want to know that you're passionate, your why for wanting to get into a field. That's the best thing you can do. Find a mentor in that area. Whoever you want to be, like anything, mentorship is key. So find somebody that you like, admire, want to be like, connect with that person, and they'll be able to guide you in the next phases of your career and things like that. Thank you all to all our attendees for participating and for your excellent questions. I'm sure we're going to have to do a part 2 because this was just so good. But we got all kind of other weeks coming up. We can do another webinar. But so we're going to go ahead and close out. But thank you guys so much, and I hope to see you in the next talk, which will be starting here within a few minutes, on breastfeeding while Black. Again, I'm Dr. Jess. This is Dr. J and Raven and Mia, who had to cut out and do some good, excellent patient care herself. Thank you so much again, and I hope you guys have a good rest of your night.
Good night, everyone.
Thank you.